I think you can see my slides now. Sorry for the delay. The normal growth parameters that we monitor include the weight, the height, and the head circumference. Growth is nothing but the physical development of the child, and these parameters reflect what we need to monitor in terms of their achieving their potential. The general timing when we review the child for growth monitoring is at the time of birth, when we assess where the child is in relation to other children of their age. This is called plotting the baby on their own percentile. The target growth potential will depend on where the child falls at this stage, as well as the family growth pattern. There are a few factors that affect the baby's growth at the time of birth, mainly the situation when the baby is in the womb, the placenta, the supply to the baby, whether it is healthy, and whether the nourishment to the baby is happening in the right pace. If the mother has high blood pressure or other conditions which affect the nutrition of the fetus, the baby may be growth restricted. And when it comes to growth restriction, as I will explain later, the growth is not predictable. So we have further checks usually at the time of vaccination visits, and this will depend on the country you live in. So usually in UAE it's 2, 4 and 6 months. In India, for example, it's 6 weeks, 10 weeks and 14 weeks. And subsequent visits can be at 9 months and 1 year. However, if there are any concerns, we will have to develop and review the child earlier. After 1 year of age, usually if the advice has been given appropriately, 6 monthly reviews in the clinic plus the parents monitoring the weight gain at regular intervals should be adequate. Some of the important facts that the parent should know about the weight gain or loss of the baby. There is always an initial period of weight loss followed by weight gain after that. The baby returns back to the birth weight by 10 to 14 days. This of course depends on the feeding, how well the feeding is established and so on. The weight gain is 20 to 30 grams per day in the first month. It then reduces, and you can roughly estimate it as 10 to 15 grams per kilogram per day. Going by the weight of the baby as a measure as well. And the parents should remember that they should go by the growth chart and the percentile of the baby's growth rather than exact numbers. They should consider apps that can be used on your phone as well that allow you to plot and monitor the child's growth trajectory. In the beginning, we can measure the weight 2 weekly. The height measurement 2 monthly is adequate. Head circumference during the clinic visits is enough, so very rarely that the parents need to measure the head circumference at home unless there is a concern with the head circumference growth. So this is an example of what a growth chart looks like. So this is for the weight and the length of boys, and the age range is mentioned here, so from birth to 24 months or 2 years of age. So the premature baby is usually plotted on this chart only after they become corrected age of term. So if a baby is born at 30 weeks, for example, they become corrected age of term only when they are 10 weeks old. So this is called the corrected gestational age. And for a term baby, you start with 0, and then as they grow older, you keep growing on that. The lines here reflect percentiles, and the percentile lines indicate the potential or the range in which the child is supposed to grow. So according to the chart that you're following, the first bottom line may indicate the 3rd centile, 5th centile, 10th centile, 25th, and then 50th centile, and then you go up on the 75th, 90th, 95th, and 98th. So percentile is nothing but a distribution of a particular measure that you're looking at in relation to population. So suppose you have taken 100 children of that age, for example at 3 months of age. 3rd centile means only 3% of the babies are below that particular weight range, and if you say 50th percentile, 50% of the babies are at that below that, and 50% are above. So that's what we call the average. So remember that your child is supposed to grow along the trajectory for that baby, and there are situations where there is catch-up growth. In some situations, like an infant of diabetic mother where the baby is big at birth, sometimes they track down a little to correct for the familial pattern. So most of the time the baby continues to grow on the smaller side in the small for gestational age, where it is due to family pattern. If the baby was growth restricted due to intrauterine insufficiency, like placental insufficiency from high blood pressure or other conditions, they may show a catch-up growth. It can be early catch-up in the first couple of months onwards, or it can be late catch-up after the first 1 to 2 years. So the factors influencing growth include the birth weight, the family growth pattern, both in childhood and current pattern of the parents. So the pattern in childhood is important in terms of constitutional growth delay, for example, where one of the parents may have late puberty and their growth spurt is delayed, and the same pattern may reflect in the baby. There may be short stature in the family, so the parents may be of normal height, but one of the grandparents may have a short stature, and skip genes can happen. And so even if the mid-parental height is suggestive, if there are short family members, you may consider that. Prematurity and growth restriction also lead to growth failure in some babies. The premature babies who are very premature, like the extreme premature babies who are below 1 kilo, may continue to grow on the smaller side even after discharge. The babies who are on exclusive breastfeeding tend to grow at a slower pace and compared to babies on formula feeds, but that doesn't mean that formula feeding is better, because the baby has to maintain their appropriate growth pattern, and overfeeding them may lead to future health problems. So catch-up growth, as I mentioned, is seen in growth restricted or preterm babies after the initial period of slow growth, and the timing varies. The best option for the parents is to be satisfied with the growth as long as the birth centile is at least maintained. So the baby should self-regulate the intake, and catch-up growth will happen when due. We shouldn't be forcing with high-calorie milk, for example, or forcing the baby to feed at repeated intervals. So that is one of the commonest reasons that we find problems related to reflux, and lack of control. Obesity becomes a problem in the future as well. So pushing the growth restricted babies to take in more than they need or use high energy feeds may increase the future risk of obesity, hypertension, diabetes, and heart disease. This is called Barker's hypothesis, or the pre-programming effect. So a child who is destined to be small, if you force them to grow faster, it's not good for their cardiovascular health. So obviously, if you are meant to be Laurel, you continue to be that way, and it's not good to become hardy in that sense. So obesity is a big problem, and we should be careful with that. So this is a quick summary. I'll stop sharing here, and we will discuss other concerns that parents may have. Let me see if you have any questions so far. Hi, Dr. May. Good evening. So one of the other questions I frequently get asked is about the milk volume that is suggested to be taken on the formula tin itself. So I've mentioned it before on my other videos on formula feeding, or how much to feed the baby, that this is usually targeting the babies who are growing on the higher centile, the babies who are above average, who continue to gain weight in that pattern. So the requirement of the baby depends on the percentile they are on. So a smaller baby will obviously need lesser volume. A rough estimate for feeding the babies can be that you give 60 ml of milk in the first couple of weeks for a 2.5 to 3 kilo baby. If the baby is 3.5 kilos, you can take 60 to 90 ml per feed. And this feed pattern is usually every 2 to 4 hours. So a formula fed baby who is getting a good volume can feed every 4 hours. In a breastfeeding baby, we don't need to be worried about the volume. As long as the baby is feeding and sleeping, go by the cues of the baby, try to feed them as best as you can. In terms of progression, you go by the percentile growth of the baby on the growth chart, how well the baby is passing urine, how well the baby is sleeping, and these parameters will help you decide. So roughly 30 ml per month is adequate if the baby is tolerating well. The baby, as they grow, you can consider increasing the volume, and by 4 months of age they reach 150 ml or so. So 60, 90, 120, 150, and then you don't need to really jump up. Each baby is different. There are babies who take 180 to 210 ml by 6 months, but not every baby does that. You don't need to expect the baby to finish that volume, and you will be starting weaning by 6 months as well, so you don't need to necessarily continue increasing the volume of formula. So be clear about how to increase. Do not follow the instructions on the tin as a general rule. And the other question that I get asked about babies is, should we give water? We don't really need water for newborn babies. When they are breastfeeding, the baby can take more water for their thirst, from the breast. The initial part of the milk, the foremilk, has plenty of water, and this will satisfy their thirst. The hind milk has more fat, and it gives a satiety and allows the baby to settle down. In a formula fed baby or in a mixed feeding baby where the stool tends to get hard, we may consider a little bit of boiled and cold water. Sometimes we may use dried prunes soaked in water, and the extract can be given to soften the stools. Breast milk itself is a very big stool softener. So if a baby is on significant proportion of breastfeeding, it's very unusual for you to need water. And the stool pattern in these babies is variable. Sometimes they pass stools once in 3 to 4 days. Sometimes some babies go even 7 to 10 days, and this doesn't indicate any problem. As long as the stool is soft, you don't need to be worried. The water intake needs to start in most babies when you start semi-solid or weaning foods, and this is typically recommended by 6 months of age, and you may consider it earlier in some babies where the growth is on the smaller side. So we have to review the need for the water, increase the water intake when you start semi-solid foods. If the stool is hard, that means you need to give more water. Try to give more fiber-rich food as well, and what we mean by dietary fiber is a fiber which is present in vegetable sources. So green leafy vegetables mashed are a good source of fiber. You may give different forms of green vegetables and mash them. Giving juices is not a good option for babies because it's high in sweet content, and even fructose is not a healthy sugar. You only need sugars as needed, and remember that it is not good for the dentition as well. So I can see a couple of questions. Let me see that. So there is a question from Anand Prakash that the baby is 3.5 months old, gained only 150 grams in 1.5 to 2.5 month duration. They've changed the formula milk, gained approximately 550 gram in 1 month. So there is no target that the baby has to gain 700 grams weight in a month. So this baby is obviously, you had issues with breastfeeding most probably, and the baby's weight was lagging behind. So the 150 gram gain in the first 1.5 to 2.5 months is totally inadequate. Ideally, the mother should have been supported for the breastfeeding, and that's why it's very important. I showed you the need for immediate follow-up and the need to make sure the baby is gaining weight. So it's very important that we monitor that, and the catch-up growth in this baby will happen, but you don't need to be worried, and continue to support the breastfeeding. The mother can express milk. The formula milk is not of a better quality. It was just the lack of settling in of the lactogenesis that the mother could not get enough milk at that stage. But now that the baby is thriving, you can relax about it. She can work more on increasing the breast milk output by regular emptying of the breast, maybe a consultation with the lactation consultant if that is possible. And don't be worried about the exact weight gain. These numbers are arbitrary. It depends on the growth pattern that's expected for your family. I showed the growth chart earlier, so remember that your baby's percentile will determine, and your baby had a slow start. You don't necessarily need to push the baby to a catch up. As long as the baby is gaining weight in a healthy way, you don't force the baby to feed more, and you continue to monitor that. So don't have a target. Have a target of daily weight gain, as I said, around 10 grams per kilo per day. It will drop as the baby gets older, and continue to support the breastfeeding. It's very important that your wife doesn't get upset about not having enough milk. The support system unfortunately is lacking in many places, and that's what we need to work on. So let's go to the next question. Mr. Balachandran, giving vitamin drops, iron drops, vitamin D3, birth weight of 3 kilos. So obviously vitamin D drops is recommended universally wherever you are, and The recommendation for the breastfeeding and formula feeding babies is slightly different, but to avoid confusion, we can stick with the same pattern. Because the formula milk, you need to reach around 1 liter of the milk per day to meet the recommended daily intake of 400 units of vitamin D. So if you say that you have to give 400 units of vitamin D to all newborn, including the breastfed and mixed feeding babies or formula fed babies, that is appropriate. And the iron drops are usually not needed in full-term babies till 4 to 6 months of age. The delayed cot clamping is a very important measure that the parent should do when they are when the baby is born. Not the parents, the medical professionals should do when the baby is born, and this will improve the iron content in the baby, and iron deficiency is reduced. In an exclusively breastfeeding baby, the iron intake is on the lower side, so when the baby reaches 4 to 6 months of age, it's better that we supplement iron. Weaning foods may meet the requirements in the families where you are going to give non-vegetarian food as well. However, if you are exclusively vegetarian, you definitely need the iron content. The multivitamins are controversial, and there is no real need to give multivitamin supplements unless your dietary variety. When you start timely weaning, if your diet is of good variety, you don't need to be really giving multivitamins. But iron supplements in breastfeeding babies, if you are on a significant volume of formula milk, usually the formula these days are supplemented with iron, so around 10 milligram per liter of the milk, and you have to verify that on the tin that it's an iron supplemented formula. Weaning foods like formulated cereals have iron supplement as well. The meat products, pureed chicken, meat can be given right from 6 months of age. For the babies, we advocate to start early if you don't mind non-vegetarian food rather than delay. In India, for example, there is a lot of cultural variation, and many families don't introduce meat till 1 year. Of course, if you have a strong belief and you don't want to introduce till 1 year, you can focus on the protein content from vegetarian foods till that stage. But if it's not a very strict rule, you can consider, because non-vegetarian food have a better source of iron. Complementary feeding, I think I mentioned that you start by 6 months of age, you start with pureed food, and then you progress with it. There are many videos on the channel. There is snippets for parents on feeding. I would request you to go through that the playlist. So the best way to go through the channel is by going through the playlists. So there is a question from Reeth. Baby is having congenital hypothyroidism. We are giving her vitamins and thyroxine. She is 23 months old and still not walking. So Reeth, obviously that hypothyroidism was detected late. I'm sorry that this happened. How is your child's development? So it depends on how well the child is developing in other fields. So delayed walking by itself doesn't mean the child is going to be significantly abnormal. So is a child having any other reason for delayed walking? Is a child standing and walking, holding on to furniture? Is a child a shuffler? So some babies are having a delayed development in terms of walking when they bottom shuffle. So this is a familial pattern. And when you say your child had developed hypothyroidism and it was detected at 13 months, was the child having significant other concerns? How is language development of the baby? How is the fine motor development? So I'll be discussing on development in detail in the next session, so we can look at that as well. You can message me more details and we will look into it. Unfortunately, the newborn screening is not still universally done in many parts of the world, including in India, even though the awareness is increasing and more people are doing it. So it's very important that we continue to do the newborn screening. We don't miss congenital hypothyroidism, and any pediatrician who is seeing children in the clinic should be on the alert for diagnosing hypothyroidism, like prolonged jaundice, constipation in the baby, or any delayed milestone. So any visit to the clinic should be taken as an opportunity to monitor their development and growth. Dr. May, thank you for your question. In a formula fed baby, you may or may not give the iron supplement. In a breastfeeding baby, you need to give an adequate dose of iron and focus on the nutrition, dietary intake of iron as well. When you give the weaning foods, you look for iron rich foods as well. Multivitamin, as I said, it's optional. Vitamin D should be continued, preferably till 2 to 3 years. but the multivitamin is optional. But you can give an iron and multivitamin complex if it has enough iron. Some of them have very small quantities of iron, and so if you need to supplement, you're looking at 2 milligram per kilogram per day. So you may have to give a separate iron formulation. However, if it is just an additional one in a baby who has reasonable sources, it may be adequate. And one more point about the iron drops is the staining of the teeth. So many of these iron drops stain the teeth, and parents should be taught to clean the teeth at that stage soon after the iron drops is given. So Reet, I think in this case, if your baby's thyroid function has improved and the baby is doing well and the child is active and starting to stand, you stimulate the child as well as you can, monitor the thyroid function, and hopefully the progress will be good. A slight delay doesn't mean it's going to be a permanent delay. So channeling the development in the right way, appropriate stimulation is going to be important for the child's development. So thank you for joining and asking these questions. Of course, many of these questions are addressed already in different videos on the channel, and you can always review the previous channels, previous videos. As I said, the parents can watch mainly the parenting related playlist. There are many videos that are coming out for medical personnel as well, so don't be confused by that. If there are any more questions, I'll wait a minute or so. So the key message is that we shouldn't be overfeeding the babies. We shouldn't be giving high energy milks just because the child appears thin. Being lean is actually a healthy fact for the baby. Pushing the baby to grow fast or to be chubby is not necessary, and support healthy eating practices. Remember that what we do in the early part of infancy is going to impact them for life. So set it well, and let's hope that it works well. So since there are no other questions, I think we will stop the session. Thank you for joining.